Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm one of your co-hosts for the AAMPT podcast. I'm excited to bring to you another great interview. Our guest today is Dr. Lauren Cornwell. Dr. Cornwell graduated with a doctorate of physical therapy from the University of Kentucky in 2019. She is a licensed physical therapist working in an outpatient orthopedic clinic at OrthoNeuro in Pickerington, Ohio. The article we're going to discuss today, which resulted from work she conducted as part of her doctoral dissertation, is titled Work-Related Musculoskeletal Disorders in Physical Therapists Attributable to Manual Therapy. You can find this article in the Journal of Manual and Manipulative Therapy, Volume 29, Issue 2. And with that as our general introduction, let's get to the interview. Dr. Cornwell, welcome to the podcast. How are you doing today?
Doing well. How are you doing?
I am also doing very well, and I'm excited to have you as a guest today on the AAMPT podcast. So let's dive right in. And while I'd like my first question potentially be, why am I a broken manual physical therapist for the quantity of hours that I use my hands in the clinic? I think we'll avoid that question and just ask you, what was it that caused this project to come into existence?
Yes. So my research advisor, Dr. Charles Hazel, he has been studying when I was beginning my first year of PT school. He was already studying manual therapy and how it's related to injury and size differences between the clinician and the patient and different alternative techniques related to all of that. And so we thought we would tie into his research and really focus on why are the injuries occurring? Is there any relationship between manual therapy and injury, manual therapy and size differentials between the clinician and the patient, and really see if there's anything out there regarding that.
That sounds like a really interesting line of questions. And before we dive into some of those answers, can you start us off by talking about what the already available evidence says on this general topic?
Sure. So the vast majority of literature out there right now does essentially confirm that physical therapists are getting injured. Physical therapists of all settings. Some studies have shown up to 91% of all physical therapists getting some sort of work-related injury, and that these injuries are occurring more prevalently either early in the career, so less than 5 years, or late in the career, so greater than 30 years of practice. And a lot of this is really affecting the practice strategies and the clinical decision-making and even the lives outside of their workplace. They're also seeing that the low back happens to be the most prevalent region of the body to be injured. And that's mainly in more of the inpatient acute care settings. And that outpatient setting is seeing more neck, upper back, wrist, hand, and elbow injuries. And we are also seeing that as high as 39% of those being injured are either changing their practice setting or completely leaving the profession altogether. However, we found that there was a limited evidence in really focusing on physical therapists who are performing manual therapy and how, why, what, and when and where they're getting injured, even though it is clearly identified as one of the top risk factors associated with injuries in physical therapists. So that's the main reason why we decided to start looking into this, because there's nothing in the literature right now that's really diving into the relationship between manual therapy and these injuries, and also how it's impacting the clinical practice overall of these physical therapists.
That is superbly interesting. And just to go back into those stats a little bit, can you say again what percentage of physical therapists are having injuries while performing their duties as physical therapists?
91%, which is crazy.
91%. That is mind-blowing. And while I am, of course, just one case study, I can report that I have had a handful of injuries associated with my clinical practice, one of which was last week. Of course, in my case, and I would assume many cases, I became my own provider, and I handled that before it became anything built up into a problem that would send me into the formal healthcare system. But that is a mind-blowing statistic. And I also noticed the general trend, and correct me if I'm wrong on this, but it sounds like the inpatient portion of our profession is having more of a lifting related injury. So maybe lifting and transferring patients, whereas those of us in outpatient, because maybe we're doing manual therapy and using our hands with, smaller, lighter weight, more repetitive tasks, we're getting injuries more in the neck and upper extremity. Is that correct?
Absolutely. Yeah. That's essentially what a lot of these authors are showing, is that there's a clear difference between body regions with the different settings, as in acute care inpatient is doing more heavy lifting, whereas we're getting those repetitive injuries.
So that's where right now in the literature, where you're taking the current study and looking, I assume for the first time, more at a specific orthopedic manual physical therapy subset within the profession.
Absolutely.
So you create this survey, you disseminate it to clinicians. Can you tell us who were the people that responded to the survey when you sent it out?
We sent out the survey to the Academy of Orthopedic Physical Therapy, which is a part of the APTA, and we received 360 members who responded to this survey. It was relatively equal between males and females being slightly higher, but not much. And we saw a wide range of demographics when it came to who responded, which was great for our results, because there was really no one to kind of steer one direction or the other. The median age was about 41 years old, and it went from the first year out of practice all the way to 30 or more years out of practice. The vast majority of them were clinical doctorates, but again, it ranged from a bachelor's to a PhD. What we found interesting, which would be important later, is seeing that 37% of those members described having advanced manual therapy credentials of some form, and that 77% said that they obtained knowledge of manual therapy techniques to reduce the risk of injury, whether that was from PT school, their employer, continuing ed, any kind of colleague, or even just self-teachings. And that 32% of them said that they did receive alternative techniques from their PT school curriculum.
So it's a relatively small sample size, but we're getting a broad swath within this subset of the profession. In terms of the results that you have thus far in this topic, what was the self-reported injury rate for these therapists? And more specifically, which type of injuries did the participants report?
So 38% of the respondents reported sustaining work-related injuries that they felt were attributable to performing manual therapy, which is huge. And the vast majority did still say that they were receiving injuries from the wrist, hand, elbow, but we did see a good percentage of other body regions, including the shoulder, the neck, the upper back, hips, pelvis, knees, ankles, which just shows that it's not just the wrist and hand that we are all thinking and that all authors are saying that we're doing. It's just a broad range of all body regions, which makes sense because manual therapy is a full body type of technique. And I feel like we really need to show that we need to, the practitioner as a whole is getting injured, not just, getting a little bit of arthritis in their thumb by the time that they're 70 years old.
It's super interesting. And as a manual therapist who's been using manual therapy for over 15 years, I certainly find that it takes more than just my hands to perform manual therapy. And I think, consistent with what you've been stating, a lot of the pains that I've felt have been elbow to fingertips. But there are other things that happen in my case, which I assume is similar to many cases. Sometimes it's hard to tell if it's manual therapy that's doing it or manual therapy plus something else. But as I've already stated, I'm lucky to be able to be my own therapist, and I can usually control those pains relatively well.
Absolutely, yeah. We actually were able to look into that a little bit. Unfortunately, like you said before, we did have a relatively small sample size. So as we got into the deeper questions in our survey, there was even less and less because there was just so much to ask. We did ask the question regarding how you were treated or how these injuries were treated. Unfortunately, there just wasn't enough information for us to really even put it in the article. But we did look into self-treatment versus formal treatment versus treatment from a colleague. And at that point, when we were looking at the numbers, we just felt that there was other realms to go into versus kind of discussing that piece. I would rather talk about how these people are changing their practice patterns and how it's affecting them outside of their work, because ultimately it's a huge professional issue if we're having clinicians be affected in practice just by performing a technique that they were learned to do.
That is a spectacular point. You already mentioned that once earlier, and I'd wanted to ask you about it, but I forgot. And that is, there's, of course, you said a huge number of individuals that are leaving the profession because of their injuries. And while that's only one potential way in which these types of musculoskeletal conditions could impact a physio, can you talk about the general topic? How is it that work-related orthopedic injuries are impacting the delivery of physical therapy services?
Again, with the small sample size, there wasn't a ton of significant information, but I feel like we gathered enough of our respondents to answer these specific questions to really at least just make people aware of it. We did look at changing career paths and changing clinical practice, and we did see that those being injured were actually reducing their work hours, transferring plan of cares to colleagues, having more of an exercise prescription, or even moving more towards therapeutic modalities, which it seems like with current literature, we're trying to get out of those kind of, if we're manual therapists, we want to be able to treat the patient with the up and coming and the new techniques and the new skills of rehab. But we found that 11% completely changed their career paths, whether that was, again, reducing their work hours, changing to a setting with less perceived risk of injury, or even moving to just general administrative roles altogether.
That's intense. And of course, we want to make sure that we are keeping people within the profession. And you just reminded me of this fun little story from a couple years ago. I was in a classroom. We were talking about manual therapy and different techniques for the application of manual therapy. And for the weeks and months ahead of that, I had noticed that for whatever reason, in the past, I wasn't there when this happened. Somebody had taken one of the mobilization wedges and used it as a doorstop. And part of me thought like, hey, that's a fun, unique usage of a mobilization wedge. But what it led to was that none of the students actually knew what the mobilization wedge was. They, in fact, thought it was a doorstop. So when I started showing them, because some of the students were having difficulties with their thumbs, for example, the people that were more flexible and their thumbs would hyperextend, I showed them how they could use this mobilization wedge and its design to help assist their fingers, their hands, their wrists, their elbows in the application of the technique. And they were mind blown because I had just taken this doorstop and taught them how to save their thumbs with it on a patient. And of course, the irony there is it was not a doorstop, and they could have benefited from that type of education before that point because they had already been in the clinic. I think what that shows is that, yeah, we can use our hands, and some of us can use them in different ways than others, but we have all of these tools and techniques and strategies that can help us save on our anatomy in different situations. And I think it's wise for people to be aware of that.
Absolutely. That's kind of the big point that we were trying to at least get at early on with kind of concluding in our study, is that as our results show, 27% of those being injured were clinicians that were working less than 4 years out of school. And it was a cumulative effect, with 56% being those with greater than 30 years of practice. But we saw that it was starting early on in your career and just accumulating over the years, causing more of the practice pattern issues later on. We felt that if we targeted more of this realm of the younger clinicians, diving into what their education background was, what CUs are they taking now, and really making aware of the clinicians and the educational programs and the clinical instructors, and saying, hey, we really need to focus on this, have a good background in manual therapy, because if you don't know the biomechanics of the actual techniques you're doing, how do you know how to change your body to a patient that may not be the most advantageous for the original technique? So then you just still do the technique because you don't know any better necessarily, and you get injured. And then that starts to build up over time until you're 30 years out and you're like, shoot, I'm tired and I want to reduce my working hours because I'm just tired of being injured so much.
Yeah, that's troubling to me. And I certainly know more than one physical therapist that has left clinical practice because of injuries. And part of what I'm hearing you talk about is that from an educational standpoint, it's important for us to make sure that each physical therapist is comfortable, not just in how to perform this technique, but how to think about the process of performing it. And it brings back for me specifically memories of my residency training. And it was the first time in that program that I saw the director really take a look at the individual performing the technique and how that technique with that clinician would interact with that particular patient. Stated differently, we have tall PTs, short PTs, we have stronger and weaker PTs, we have people like myself with stiffer hands that can, not go into hyperextension and perform the technique this way compared to someone else that's more flexible and they have lots of hyperextension. And prior to that point, I had always thought about the technique in terms of this hand and that hand, the forces in this direction, and maybe we're thinking about biomechanics in the joint, maybe we're not. But it was all about, here's the way it's described, so here's how I'm going to do it. But it's really, I think, much more of a world of possibilities and variability, and each one of us needs to find this different personalized pathway to make sure that we're not only helping the patient to the maximum possible benefit, but also not hurting ourselves and harming ourselves in the process.
Absolutely. That's exactly what we were trying to get at with this survey, is just at least making people aware, like, hey, this is a problem and we need to be better educated early on to really understand these techniques so we can start to learn alternative techniques to adjust for every single patient.
Yeah, I couldn't agree more. And one of the thoughts in my head right now, and I know this is outside the scope of the study that you just had published, I'm wondering about, and I'm actually worried about the clinical outcomes of different subgroups of therapists. For example, you have the physical therapists that are doing a better job. They're less injured. They're having less pain. So they can use the technique that is, let's say, more effective and efficient. Their, let's call it first line choice of treatment based on their evaluation, their assessment, et cetera. And then those other physical therapists that have deviated from what they think is the best plan for that patient because they're having pain or disability or some other obstacle with implementing that treatment technique. And the thing that has me worried is that if you're choosing treatment options that are substandard based on your evaluation and your assessment of the patient, then might it also be true that your results are going to be substandard? And that, of course, in my mind is unacceptable because we're here to help patients and we need to find a way to make sure we're maximizing their benefit from clinical services.
Absolutely. That would definitely be a very interesting research study to look into. But it makes sense. You can do your own study every day when you go to work. It's just who's injured today and how are they changing their practice patterns, whether or not they're injured today, but even like maybe they're afraid to get re-injured from past injuries and now they've completely changed their clinical practice. And I've seen some, even in my short time being a clinician, some just avoiding manual therapy altogether because they just don't want the risk again.
I've seen that as well, and it's always a little bit troubling to me. And, while I am here representing the American Academy of Orthopedic Manual Physical Therapists, and I am, based on my education, biased towards manual therapy. That in some ways is partially beside the point. Whether it's manual therapy or some other form of clinical treatment, if we're not picking the treatment that we think is best for the patient, then there's a problem inherent in that. And I'm so fascinated by the topic, and I can't wait to see what further research comes out of this line of thinking.
Absolutely. Yeah. I hope that this article kind of spurs more conversation to allow for further studies and looking into either diving into this younger clinician population, really diving into, are they getting injured? What's their rate of injury? And also looking into their education up into that point. Are the PT schools doing enough to train these clinicians for manual therapy? And if they are, then where are things lagging? Are they not taking enough courses once they get out of school? Or are they just losing all of that education? And to flip that, I was also thinking of other realms that you could further this study and looking at actually body size differentials between the physical therapist and the patient and diving into that realm. Is it the height, stature, general weight of the clinician the problem? And we're needing to really tier for those clinicians to have alternative techniques? Or is it just general lack of education in the manual therapy realm?
Those are great questions, and I would love to see the studies as well as, of course, the results from those studies in terms of what it indicates for our profession. Part of what you've just done also is to remind me of a couple things from my past. And, I'm going to call myself an average size male. I am, of course, smaller than some physios and larger than others. And being a manual therapist on top of that, I've been one of those people that has been given the larger, stiffer patients, typically, or maybe I should say stereotypically, from a small female clinician. They'll come to me and they'll say, the leg is too heavy or the person's too big and I just don't feel like I can generate enough force. And oftentimes these patients are also too big for me. And I'm thinking of one patient in particular, although there are a litany of stories here. And this guy was, built like a huge boulder. He was considerably taller than me. His shoulders were huge. His arms and legs were huge. And it just felt like I was trying to take a bat to a tree trunk when I was working on him. And everything just kept saying, he's stiff. He needs to be stretched out. I'd try that and he'd feel great for an hour or 4. But then the benefit from the therapy session just wouldn't last long enough. So we'd slowly treat more aggressively, trying to find the right dosage of the treatment. And I literally ended up spraining each of my thumbs on this man's sacroiliac joint because my quest to find the right treatment dosage for him, following the pathway of what was surfacing as the thing that he needed, I hurt myself and I had to change my treatment strategy for, I think if I remember correctly, it was between 10 and 14 days. It's really hard to be a manual physical therapist without thumbs for 2 weeks, but I had to do it, and including with him and patients before him and patients after him. One of the strategies that I've tried to employ, both with the larger, stiffer, harder to treat individuals and the smaller, lighter, and more flexible, is I try to teach the patient how to use their body weight in a self-mobilization as part of the home program. I want to use gravity as my assistant. I want to use their ability, maybe with a less effective treatment, to stretch it home and use it more often so that not only am I teaching them independence, but I'm also, yes, saving on the wear and tear of my thumbs, my wrists, my elbows, etc. I find it works spectacularly well with some patients, less well with others, but overall, it's been a good addition to my clinical practice, and I continue to experiment with it.
That is a great example to just tie in with this research is obviously you've been injured because you've had to treat patients that may have not been the most advantageous for you. But then tying into the other side is that you knew the body mechanics and the biomechanics behind what you were trying to achieve. And you just asked questions. How can I make this better for me? How can I make this better for the patient? I feel like self-mobilizations are something that could be more educated on because they are relatively easier to perform. And if it works, why am I going to destroy my body when the patient can simply do it themselves? Obviously, it's not going to work every time, but I feel like that's one of the big things this is trying to get at is, do some clinicians even know that there are those type of techniques for self-mobilizations for a lot of different body regions, not just the SI joint or the spine, but just for any kind of body region?
I completely agree. And of course, we would be remiss if we didn't mention all of the other things that we know from the scientific literature as well as clinical practice can be good for our patients with musculoskeletal pain. And that brings us to the biopsychosocial model. Individuals often need aerobic exercise. They might need to improve their diet, their mental health. They have to alter how they're doing something mechanically at work, at home. There are just so many different avenues that we can go down. We, of course, should look at the whole picture. But on top of that, when we're doing manual therapy, as it's indicated, beneficial, etc., we should make sure that we're doing it wisely, effectively, and efficiently.
Absolutely. I completely agree.
Well, Dr. Cornwell, this has been a spectacular conversation. It was a pleasure to have you on the podcast. I thank you for your work in this area. And before we end things, I just want to ask you, and I know you're relatively new to the profession and clinical practice, but do you have anything planned for the future? Any sort of clinical or academic education? Are you planning a follow-up study? Is there anything that we can look forward to seeing from you in the future in this realm or a different realm within the physical therapy profession?
Thank you again for having me on the podcast. Currently, I think my main focus is really just beginning to educate, especially starting at my job and further educating other clinicians on my current research. But as of right now, I don't have any other studies.
I think that sounds wise. I, of course, myself as well, had to jump into the profession, get comfortable, pick that one topic and move forward. But as you fill out the rest of your career, there's no doubt in my mind that we'll see great things from you at some point in the future.
I appreciate it. Thank you so much.
You are welcome. And once again, thank you for being on the podcast.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.